So the next session is choice of therapy. So what I thought we would do first is we would get Dr. Chu to review some of the indications for radiation, just as a start, and then we could kind of move forward from there. So would you mind presenting?
Perfect. Thank you very much.
Awesome. Thanks.
So, patient diagnosed with biopsy-proven clear cell renal cell carcinoma on the left side. As you've heard from Dr. Kapoor and from Dr. Black, the standard of care for patients with localized primary kidney cancer is still surgery. It's still the gold standard treatment. And if they're not eligible for surgery, then there's also thermoablative options that we talked about last night, and Dr. Kapoor is an expert in that, either radiofrequency ablation or cryotherapy. Highly successful for early stage lesions, typically for less than 3 centimeters. Even if they're a little bit bigger, repeat procedures are highly successful. But another option that's emerging and evolving is active surveillance, just following patients along with imaging and physical examinations along the way to really defer any treatment and treatment-related toxicities until such time they actually really need treatment. And these are evolving and certainly part of the guidelines across North America and worldwide. But if you recall, the patient I discussed early on, she had a growing tumor, was not eligible for surgery, and based on her tumor characteristics, she's not a candidate for a thermoablative approach. So we talked about radiotherapy in the primary setting, or stereotactic radiation treatment is potentially an option for a patient who has medically inoperable renal cell carcinoma. The reason the question is why? Why is it an available option? Data to date from pooled meta-analyses from at least 10 centers across the world shows that stereotactic radiotherapy results in good control of the primary tumor with local control rates that exceed 95% at 2 and 4 years. It's well tolerated, and these mainly are for patients who have large tumors. We're not talking about small tumors that can be addressed by surgery or thermoablative approach. These tumors are generally greater than 4 centimeters in size, and overall, well tolerated, safe, with minimal impact on renal function. And this is what the data shows based on the analysis from Worldwide Institute that was published last year in 2018. The interesting thing is that also in terms of what the oncologic outcomes look like is the overall metastatic rate for patients treated with stereotactic radiotherapy is only about 7%. Interesting to know is that when you looked at the analyses for patients on a surveillance protocol, is that the metastatic rate is actually over 20%. So something to think about in terms of radiation treatment. And bringing it back to the beginning about the participation in trials, you know, when I first participated in my patient forum 6 years ago, myself and Dr. Swaminath and Hamilton are thinking about how do we bring SBRT forward as an accessible treatment option for patients with medically inoperable renal cell carcinoma who don't have treatment options like the patient I presented today. And it's because of participation in research in our pilot study that we just completed between Hamilton and Sunnybrook that enables us to be here today to present you with these good results. We contributed to that worldwide meta-analysis. We've completed AQUOS 1, which is a pilot study between ourselves and Hamilton, and building on the data and our experience has really allowed us now to move forward to a Canadian prospective phase 2 trial in order for us to enroll more patients to better study the role of SBRT in localized primary kidney cancer, but also want to acknowledge the patients that have participated in this study so that we've been able to learn and will hopefully continue to learn and not only help patients with a new diagnosis of kidney cancer, but also allow us to further develop and improve our treatments. Now that's in the primary setting. I talked about for stereotactic treatment. Dr. Kapoor and Dr. Swaminath are also asking an important question about what about the role of thermal therapy and SBRT for small localized lesions. Their trial just opened within the last 1 or 2 months. It's going to answer an important question, where the role of SBRT or radiofrequency in terms of oncologic outcomes, and the question about response or biopsy rates after treatment within 1 year. So participation in that study is going to be crucial to answer some important questions that are still burning in the field. And then we heard about this a little bit earlier, and this whole new emerging area or reemergence, or that what was old is now new again, about immunotherapy in patients with metastatic renal cell carcinoma. This is a summary that highlights the current state of the art in terms of our understanding of what the potential role of SBRT is in modulating a tumor's immune response and the potential ability of tipping the scale between immunosuppression and immunogenic, or enabling the body's responses to immune responses to kill the tumor cells. There's certainly an emerging role in certain combining SBRT with immunotherapy in light of the data of IPI with Nivo in the metastatic setting. And as you heard, in terms of the Carmina trial, what the role of cytoreductive nephrectomy could be with the data, that in itself has led to a rationale and hypothesis to formulate this study led by the team in Hamilton, by Sebastian Hunt, Dr. Swaminathan, and Dr. Kapoor and ourselves, is that can we combine stereotactic radiation treatment with immunotherapy in patients with metastatic renal cell carcinoma? The take-home message is, in terms of choosing therapy, one, you have to be an advocate for yourself, ask for the possibility to participate in clinical trials, particularly with radiation treatment trials, and if not, then through Kidney Cancer Canada that we mentioned earlier, we can certainly connect you to the right people to at least provide you with the information and potentially consider access. Ultimately, what we're trying to do, and we'll be thankful for you to participate, is help us answer future questions with regards to how to take care of you with radiation treatment. Thank you.
Are your trials limited to clear cell?
Which trials? In terms of the...
Well, that one specifically, like your
no.
SBRT trials.
The SBR trials for primary, they're not limited to clear
for
cell,
metastatic.
for metastatic. In terms of the criteria, not specifically at the moment, but we're working on finalizing the protocol. Yep. But certainly you have to be eligible for the immunotherapy because it's a key component of the therapy in terms of the study. Yep.
Hi, just a quick comment. I wanted to thank Dr. Chu and Dr. Noonan, because previously you mentioned, for giving the heads up for Kidney Cancer Canada. We so appreciate when specialists invite patients to become involved in clinical trials and giving information to patients that visit your practices, because that doesn't happen in the norm, and although it should. And I just want to say we so appreciate your cooperation in sending patients. Thank you.
No, you're very welcome. And I know each of the studies that are patients that participate in AQUOS, I'm indebted to them, because without their participation in allowing us, myself and teams in Hamilton and Ontario and the rest of the country, we would not be where we are today in order to potentially move SBRT further into your communities. Right?
Thank you. Thanks a lot. I think there's an explosion of immunotherapy. I think one of the main questions that we have is, what are the contraindications to immunotherapy? So I wanted to put that to Joanna to answer.
Yes. So when I'm thinking about certain options of systemic therapy for a person, I think most of us standardly would look at the individual, and we take our time to understand any health problems related to that individual. And in this era of immunotherapy, what's really relevant to us is a history of autoimmune diseases, because if the immunotherapy works by taking the brakes off of the immune system, and if someone has a pre-existing autoimmune condition, that person can run into problems with more serious toxicities. So there are some situations where, so we screen for that, and you might notice your oncologist asking specific questions about a pre-existing history of autoimmune conditions. Some are very manageable and are not thought to be serious or a serious contraindication of immunotherapy, but there are some that we do take very seriously. And I think a prime example of that is a history of inflammatory bowel disease like ulcerative colitis or Crohn's disease, and we'll be thoroughly asking questions about the status of that. Is that under control? Are you on active immunosuppressants? And so I think in this era today, your medical history is very important to us, because while we want to offer the best therapy, we also want to take your safety into consideration.
Mm-hmm. A follow-up question to that is, what do you think the role is now with using upfront immunotherapy? What about you have a patient that has a oligometastatic progression? So progression in, say, a couple of lymph nodes or a couple of pulmonary lesions. What's your approach to that?
While on immunotherapy?
Yes.
Yeah. So that is a good question. Sometimes there are these areas where it's not clearly obvious if progression is true progression in the era of immunotherapy. So sometimes I tell people that it takes time for us to understand if immunotherapy is helping that person, because sometimes the immune system can work by causing inflammation at the sites of disease. And when we scan people, things might look radiographically bigger, but it doesn't necessarily tell us what's happening at the cellular level. And so we look at the individual, their blood work, how well they're doing, and sometimes what we do is recommend another CT scan to have another look at these same spots and to see, is it truly getting bigger? So it does take time. It's not as straightforward as in other, for example, with cytotoxic chemotherapy in other disease sites. If things are getting bigger on chemotherapy, we have very good reason to believe that it's not effective for that person. But in the era of immunotherapy, it's not quite as straightforward. So we use different factors to make that to sort of help that person along. Excellent.
Yeah. Peter, you spoke a lot about, or a bit about, the use of consolidative nephrectomy, particularly in the setting of, say, if you have a poor risk patient that goes on goes on Nivo/Ipi and has a wonderful response. Have you had any issues with patients who have been on immunotherapy with respect to perioperative risk, or how have the outcomes been from the immunotherapy perspective, and also from the patients on sunitinib? Do you have any concerns about wound healing, complications from that perspective?
So I think we have more experience with sunitinib and the targeted therapies. And there you definitely want a period after surgery where the patient's allowed to heal without having the drug. So usually we'll stop the drugs for about 4 weeks and let the wounds heal, because there's an increased risk of the wound basically opening up again. With immunotherapy, I think we in Vancouver, I think we have a lot less experience, but I know from sort of the general experience that that immunotherapy doesn't usually cause problems. There are trials of, for example, pre-nephrectomy neoadjuvant therapy where you can go right to surgery without concern. So I don't think it's a big problem.
Great. Yeah. And in the setting of SBRT, any issues or concerns with either immunotherapy or sunitinib, or?
Early on in the targeted therapy area, we certainly had concerns. We're very conservative in delivering SBRT either before or concurrently. I was very fortunate over the last few years being able to work with Gary Bjarnason side by side in our clinic on Thursday, so we had always a close dialogue and conversation about being careful about when we would offer SBRT and what sort of side effects did we look forward to. Early on, we didn't want concurrent or overlap of the drugs like sunitinib, but now that we've developed a number of years and really seen very little toxicity, is that we're a little bit more comfortable in potentially offering overlapping therapy, particularly for a patient who has rapidly oligoprogressive disease where they've been increasing doses of sunitinib, yet the tumors are still growing. And if you hold off to account for time for radiation treatment planning and the treatment delivery, where they could be potentially offered treatment for 2 to 3 weeks, that we worry that the tumor may actually grow, then we may actually, in certain specific cases, with a conversation with the patient and with my medical oncologist, that maybe we should push forward with concurrent therapy. We have done that, and so far we've been pretty good, and I certainly know a lot of the patients have shared in Ascend on our experiences with the even trials patients has been fairly safe. Immunotherapy, as we all know, is a new area, particularly with radiation, as I highlighted. We know that there are potential immune effects, and just by mentioning the fact that stereotactic radiotherapy can actually be a primer to potentially boost the immune response or boost the antigenic presentation of cells, is that we have to be very careful and cognizant, because it's funny, because I just saw a patient on Thursday. He was on nivolumab, who had a wicked vasculitis he's still recovering from over 6 months. He's lost a finger and several toes, and it's a terrible, terrible reaction. But we also, so that's something to be very cognizant about. We also know that radiation treatment can lead to what we call the abscopal effect, meaning that the tumor that we're targeting actually shrinks, but other sites of tumors or other metastases can shrink. Now that's in the old days of conventional radiotherapy, the low doses every day, but in stereotactic radiotherapy, when we know that we potentially can prime the immune system, we have to be extra vigilant, extra careful that we may even cause higher levels of toxicity when combined with immunotherapy. Something we're going to learn, particularly on the CytoShrink study, really as we're developing that protocol, what sort of adverse effects outside of this traditional radiation ones, but also the immune-related adverse effects, we might need to develop an even more comprehensive panel.
Yeah, oh, absolutely. Any questions from the audience? No?
So it's great that we have all these new therapies, these new techniques. There's a lot of drugs on the market now that weren't there before, so it gives the patients a lot more access, a lot more options. How do you deal with a patient that has had treatment years ago and now is coming back into your office, into the system, because they've had a reoccurrence? Where do they fit into this rapidly evolving mix where the first lines are becoming second lines and we have these new entrances?
Yeah, I think that's a really great question. Joanna, how do you approach that? What's your risk stratification?
So I'm not sure if I understood the exact scenario. Someone who's had metastatic disease initially, who was on therapy that and then stopped and then developed like progression, or someone who had a nephrectomy for a localized disease and then developed metastatic disease?
So I guess it's a little bit of everything. So somebody that's had, that they've had maybe 3-4 years progression-free and now they have progression again, or somebody that may have had a partial or a full nephrectomy years back and now they've developed another kidney cancer, or they've developed cancer somewhere else, like on a lung met or something. So there's all those options, right?
Yes.
But the whole, so the environment is rapidly changing. And we always are talking about the new patient coming in, and you now have a new first line, or you have SBRT. So we have a process or the protocols now for the new patients coming in. But what about all the patients that are re-entering your offices with any of these conditions?
Yeah, that's a loaded question. So I would say how things have changed in this last year for sure. If we start with the de novo, so the brand new patient who has a diagnosis of metastatic disease, this risk stratification is relevant to us now. So when we look at the factors that make poor risk, intermediate risk, and favorable risk, Dr. Black has sort of alluded to the criteria. There are some lab parameters that we look at. We look at time from diagnosis to the time of therapy, and also one's functional status at that time. And when we can stratify on that individual's presentation, then sometimes we recommend a combination of immunotherapy if they're at quite high risk situation versus in a favorable situation, we would still recommend a tyrosine kinase inhibitor with sunitinib. And then in addition to that, that individual is really important to us. So where are they in their life? What health problems do they have? These are all relevant things because, again, side effects are real, toxicity is real, and we want to make sure that we're as safe as possible when we consider options of therapy. When it comes to someone, so in my mind, if I had someone who had metastatic disease who was on a therapy in the past, but we stopped for one reason or another, and I continue to follow that person and they develop progression, I would probably still categorize that as someone's having had a first-line treatment in the setting of metastatic disease. But if they've been off of that therapy for a long period of time, I would still consider a re-challenge of that quote-unquote first-line treatment because they were sensitive to it before. So those would be some of the things that I would be thinking about. I'm not sure if there's any other comments about local, like a new primary or...
Yeah, I mean, I think there can be, I guess there are two scenarios. One is a patient who's responding everywhere to systemic therapy and responds for a period of time, and then has progression in one spot or a couple of spots, and we would, coming from a local therapy point of view, we would potentially address that with a local therapy, whether it would be with radiation or surgery. Surgery would generally be around the kidney. Sometimes maybe the patient had a partial nephrectomy before, develops metastatic disease, now comes back and has a new primary in the kidney. And I was talking to a patient in the room, a patient of mine who's had that scenario, and just this week had ablation of the new primary in the kidney. So we'll still go back to our general measures for local control and whatever the current standard is. So maybe the stereotactic radiation. This wouldn't have been available to the patient a few years ago, but maybe it is now. So we always will just plug in the new tools.
I should also add there's another scenario of individuals that I think we've all seen who have, biopsy-proven metastatic kidney cancer, but they are in a smaller proportion of individuals who they have very indolent behaving disease, meaning we can scan them periodically and these small lesions don't really change in size, or they wax and they wane. So some get a little bit larger, some get a little bit smaller, some go away completely, and we can just follow those individuals. So I certainly have, and I think we all do have people in our practice where there's been no institution of a systemic therapy over many, many, many years, and they can just coexist and live with these spots, and we can just watch them over time. So I think another thing that we look at is pace of disease when we see a new diagnosis. So can we watch this person over time and reserve drug treatment until we absolutely need to? So that's another factor that I would say comes into our mind.
Definitely, I agree with Joanna. There is a patient that I share with Garrick in Toronto who was on drug therapy years ago and then developed olive progression in the lung. We removed that surgically. And just to build on Dr. Black's point, is the notion of metastectomy really isn't the method. It can be surgical removal or potential ablation. The ultimate thing is the local therapy. And this patient had that portion of the lung removed, but then also had 4 metastatic deposits that were growing in the pancreas. And what we did was we moved ahead with, he was ineligible, not an ideal candidate for, as you heard earlier today, a Whipple procedure, because he had other sites of disease that were otherwise stable. And at the end of the day, he didn't want to proceed with the potential morbidity and side effects of the Whipple, so we moved ahead with a stereotactic approach. And those have been controlled over 3 or 4 years. And just last week, he's come back with another site of oligometastatic down in his thigh. And we'll move ahead with stereotactic therapy, obviously following consultation and conversation with our orthopedic oncologist to whether surgery is an option or not. And in terms of recurrence of a primary, patients similar to Dr. Black's experiences who've had a prior radical nephrectomy has now, 6-7 years out, developed another isolated lesion. We've gone back and sent him back to his original urologist to talk about surgical resection, whether that be a partial nephrectomy, and a consultation for potential stereotactic treatment. And it really depends on what the patient wants, and his overall patient and tumor factors will drive our decision about one way or the other. But stereotactic radiotherapy in terms of solitary kidney is also a feasible option as well, obviously under close study.
Great. Another question?
You mentioned rechallenging a patient who's been off treatment for a length of time with the same treatment. What about rechallenging, like say a patient has gone from one treatment to another, like for instance I started with pazopanib, but say after 5 or 6 years on other treatments, can you rechallenge with a TKI? I know you can't with immunotherapy, but what about that?
I think the context is important with that. So I think if one stopped therapy because of toxicity, but it was an effective treatment, I think in our minds we would try to find if it's an alternate solution to that same tyrosine kinase inhibitor, to reducing a dose or switching to another in the same class, I think would be reasonable. If someone presents with a story of progression, confirmed progression on a tyrosine kinase inhibitor in that same class, I probably would not feel strongly about going to the same treatment. But as Christian had mentioned earlier, there are various forms of tyrosine kinase inhibitors that work slightly differently. So axitinib, for example, is not really in the same class that we would consider pazopanib or sunitinib. Similarly, there's cabozantinib, and they all work mechanistically slightly different. So I think it depends on your story and your experience and sort of and your toxicity profile, those kinds of things to be able to help determine that.
Great. Another question?
The other thing is, the other thing is that are you able to go back to the first treatment after you've been on others in terms of funding? That's the other caveat there, right?
Yeah, I think that's the biggest challenge that we all face is trying to convince the funders that the patient should be restarted. In certain situations, you're able to actually add the comments in the comment section. You can be explicit and say the patient came off due to intolerance and they were responding. And so if it's, biologically, if the drug is working, we may potentially be able to get access to that, but it's been challenging for me. I don't know about you, Joanna.
Yeah.
Yeah. Yeah.
I'm back with just a comment. I've noticed in the conversation with this panel and with other panels, and I wanted to bring attention to the patients, that the cooperation between the different practices like SBRT, oncology, surgery, it is very heartening to me to see that there's conversation between all. And I'm pointing out that this is what happens in centers of excellence, and I know sometimes that word is misused, but this is us that we're taking care of. And I can't stress enough to patients to make sure that you feel comfortable with your treatment and that you're being heard at your doctor's. This is your life that you are looking after, and you need to have the right information from the right doctors. And I commend you all. Thank you so much for sharing with us and showing us that there are centers of excellence and they cooperate in like round tables, so on and so forth. You understand what I mean? Thank you.
Thanks a lot. Great.
Hello, we have questions from online. I promised I would get those questions. So from the online folks, thank you very much. One question we missed early today. This comes from Ali. What is the best treatment for metastatic disease and bone mets? Is that a question that you want to, and I know this is a challenge, and because maybe we'll start with Joanna, what's the?
May I ask? Another question is, which line of therapy is this referring to?
Good question. Doesn't say that. Yeah.
Yeah, I think maybe probably answer it for the first line and then second line.
So I think also, is this in an ideal situation or what we have available, like?
I would give the answer on both of those, and then they can take the one they want.
So ideally, if I had zero restrictions in the first line setting of metastatic kidney cancer, I would be in favor of first line immunotherapy with a tyrosine kinase inhibitor. An example of that is pembrolizumab and axitinib. In the setting of, if I'm in a resource restricted setting, then at the moment I would be stratifying by risk category. And if if an individual met criteria for intermediate or poor risk, then assuming no contraindications, I would be recommending a combination immunotherapy with nivolumab and ipilimumab. And if you had presented with favorable risk criteria, then I would be recommending and having a conversation about a first-line tyrosine kinase inhibitor such as sunitinib. So that would be my general approach.
Can I throw in something there? So we diagnosed a patient this week with that scenario, and we are planning on cytoreductive nephrectomy plus SBRT to bone mets. So that's the more favorable end of the disease spectrum.
Another question, there's one from Jim online. For drugs like cabozantinib, it seems as though oncologists suggest taking the highest dosage as frequently, daily, as possible for as long as possible. What evidence is there that thinking is better than a more balanced approach with regular breaks?
That is a tough question.
Isn't it? Eh? It's a great question.
So I might actually have a shared answer. I'm going to rope Kristen to this as well. So personally, I don't have a lot of experience with cabozantinib myself. It is not publicly funded yet. So we try to get access previously through a compassionate access program. But in my practice, I would follow the original trial criteria and their protocol with standard dosing and titrate and dose reduce if necessary, if there are toxicity. So that would be my approach. But generally, these therapies, like people who've had experience with tyrosine kinase inhibitors or other tyrosine kinase inhibitors, is taken until progression or toxicity, or this person wants to go on a break, obviously.
Yeah, I think most oncologists, we like to be purists and go with the level 1 evidence. I think most of us realize, though, that the full dose is pretty tough, and so I think weekly nursing phone calls are really critical. Looping in the nurses is really important, and early dose reductions to prevent the worsening of side effects is really, really critical for these patients. Anyone else? Okay, great. All right. Well, thank you very much.